Welcome, everybody, to another ALK Talk. We have close to 70 ALK Talks, and we've had 70,000 clicks on YouTube. And Summer or Dana can link up our YouTube in their chat. Then you can go to there. And a lot of times, maybe these talks don't resonate with what your issues are of the day, but you can find them on our YouTube channel when you run into that problem, or if you want to see a particular doctor speak about a topic. So please check it out. And I know our summit's coming up, and it's super excited. We won't be joining on Elk Talk until after Labor Day, and we're going to resume. This is our fifth season, I believe, doing this. So, and I'm from Michigan, West Bloomfield. This is my 12th year as an outpatient. And we all started out in 2000 and basically just set up two different, I'll talk, there's really two different things. We talk on Sundays with doctors, and then during the week and during the month, we have a calendar of events for you to meet other Alkies and connect with other people around the world. And it's really super amazing. And when you go to YouTube, and this is probably just for a recording, but for people that aren't great with English, you can set your own language to it, and it'll go ahead and transform that over to your language. So, anyways, I'm gonna do some polling questions first. When were you diagnosed? Summer, take it away.
Oh, sure thing. When were you diagnosed? 16% of you have been with us for just under a year. 14% of you diagnosed 1 to 2 years ago. 13% 2 to 3 years ago. 13% 3 to 4 years ago. 16% 4 to 5 years ago. Another 12% 5 to 6 years ago. That'd be me, everybody. Just celebrated year 5 on my wedding anniversary the other day. 6% of you, 6 to 7 years, 4%, 7 to 8, zero, no 8 to 9 years, but we have 6% of you 10 years or more. So that is so cool.
Right. Okay, second question. What is your current treatment?
Okay. What is your current treatment? We don't have anybody with us tonight on crizotinib. 5% plus me, brigatinib is here. 48% of you are on alectinib. 31% of you are on lorlatinib. 5% of you are on chemo and a TKI. Nobody yet on the gilteritinib trial. Hopefully that will be changing soon. We have 6% of you on the Nuvalent trial, 3% of you are on another trial, and 3% of you are no treatment at all. Thank you, Mark. This is so great to give a picture of who is in our audience tonight.
Okay, this is a two-part question. Have you progressed? And if so, where was your progression?
This is a great one. Okay, have you progressed? It's a little less than half and half. 40% of you have experienced progression and 60% of you have not. So this is actually great for tonight because we're taking it back to the basics a little bit. Um, I'm sure we will have some people in our community that can weigh in as well. And two, if you have progressed, where was it? 30%. 34% of you had lung progression, 47% brain, 25% bone, 16% in the lymph nodes, 9% pleural effusion, 3% pericardial fluid, liver 9%, and 6% other. Thank you.
Right. So those are my polling questions. Now, like I said, I want to say to you guys again, use the chat, stay muted, and I'm going to turn it over to Summer.
Thank you so much. So, Summer Farman here from Hershey, Pennsylvania, diagnosed in just 5 years ago in the summer of 2020 on my 21st wedding anniversary. And this year I celebrated my 26th anniversary just a few days ago. And I got all the way till we were home from ice cream before I was like, it's my cancerversary too. So I was so happy that did not overshadow the day. So happy to be here with all of you this evening. We have a great crowd for July 4th weekend. This speaks volumes about Dr. Lou, who, sneak peek, will also be with us at Summit. So as Mark said, this is his second time with us on ALKtALK, and then he will also be joining us in San Diego. So whether you are there in person or virtual, you will get to see him again. As Mark said, he does not have slides, but that's on purpose. That's all manufactured for our little fireside chat. Or, to make it summertime, we'll say like we're roasting marshmallows on a bonfire side chat. So get cozy, everybody. Get ready with your questions. Also, like I kind of foreshadowed a little bit and said we're taking it back to the basics. There are things we see in the support groups all the time. What do I ask my doctor with progression? We know that the majority of us, that progression is on the horizon, not if I progress, but when I progress. So tonight's talk is really kind of laying the groundwork, planting little seeds for questions or a plan of action that you can make with your doctor. So when you're laying in those scans every 3, 4, 6 months, you're equipped with what's next for me. So again, Dr. Lou is here with us on the Sunday evening, bringing his insight, but always talk to your oncologist too, and your care team as well. Or feel free to share this ALKtALK once it's edited with your team. So we have Dr. Lou with us tonight from Georgetown Lombardi Comprehensive Cancer Center. He's a medical oncologist, an associate professor of medicine, a director also of thoracic oncology, head of developmental therapeutics, and he could probably run this all much better circles around Mark and I, because he is also the esteemed co-host of the IASLC podcast, Lung Cancer Considered, with one of our favorites, Dr. Nargis Flores. So it is so awesome to have you with us tonight, Dr. Lou.
No, thanks for having me. Between this, our previous episode and the summit, just want to be sure that everyone gets sick of me.
Right. We love that. Good. Better for them to be sick of you, not just us. So that's perfect. Okay, so let's get anything you just want to kick off with ALK positive cancer, anything that you feel like has happened in the past year or that we want to say to start.
Yeah, I think that it's changing a lot. And one of the things you see behind the scenes is there's a lot of heterogeneity, meaning not every ALK cancer is the same. And I would argue that no ALK cancers are the same. We know now that ALK fusion positive lung cancer is very different from a wild type cancer, from an EGFR mutant lung cancer. They behave different biologically. We treat them very differently. But within ALK fusion positive, there are a lot of different variables that maybe lie beneath the surface, different details about that specific fusion, other mutations within the DNA, and all the characteristics of our own body and our own immune system and the makeup of the body that really make each cancer individual. So we apply these large data sets to try to find the best treatment, but it really is an individual process. And I think we're just scratching the surface on that. I think in the next couple of years, we're going to see a lot more personalization of treatment, both in terms of efficacy, how well things work, and the toxicity in terms of side effects. So stay tuned for that. But ALK lung cancer is not one lung cancer. It really is a family of related lung cancers, but there's a lot of differences between them.
Absolutely, which will lead into our talk on biopsies, right? Because that's huge. So first, talking about scans. So I mentioned, okay, we scan every 3 months.
I think Summer froze. I think she was saying that we do get scanned every 3 months.
Was it me frozen?
Yeah, you were frozen.
Oh, that's so annoying. Sorry, everybody. Okay. But yes, Dr. Lou, how about you? What do you usually have your patients do?
So scanning is also pretty individual. Let's talk about the different types of scans that are out there. Early modalities of scans we don't really use to gauge cancer progression, like X-rays, ultrasounds. They're just too inaccurate. And so we're really relying on CT scans, PET scans, and MRIs. All right, so CT scan is going to be our standard type of scan because this really gives us the accuracy, the resolution to measure size. To size involvement for many organs, such as the liver, lymph nodes. You need to give IV contrast to really appreciate that, to really get accurate measurements. For disease or tumors that are in the lungs themselves, you don't necessarily need the contrast, but there are other parts of the body where the contrast is helpful. Contrast is something we have to consider because it can affect the kidneys. And if our kidneys are not working well, contrast can be a little dangerous. Also, some people are allergic to contrast or have a reaction to contrast. And so we have to sort of balance the need for contrast to really get a clear picture as to what's happening with the cancer versus any types of side effects or reactions you might have. We use PET scans sometimes. PET scans are basically when we do a scan and we give a radioactive sugar that binds to a tracer that's injected. PET scans take a bit longer to do, but the PET scan will help us localize area where there's sugar uptake. And that generally will show us where there's a lot of activity. There are some parts of the body where there's always activity, like the brain, like the left ventricle of the heart. There's some parts that are always hot in the PET, like the kidney and the bladder, because that's where the tracer eventually is secreted. So PET scan is not good for looking at those parts of the body always. And a PET scan is not useful at looking at size. And so when you do a PET scan, you sacrifice broad activity, which can be helpful and give us some clues for things that could be missed on a CT scan, but you sacrifice size. They are often done in conjunction with a CT scan at the same time, but it's sort of a low dose CT scan, sort of a rough CT scan. You can do a high quality CT scan, but it takes a little bit of coordination. And of course, the one variable in these scans is insurance. Insurance does not always allow us to do PET scans. And so if a PET scan is necessary, then we can appeal insurance, or sometimes patients will pay out of pocket. But I will say most of the time a CT scan gives us the information that we need. And we can talk a little bit later about when to do a PET scan or how often we should do PET scans. And then we have MRIs. MRIs really are how we look at the brain. There's some rare circumstances where we'll use an MRI to look at other parts of the body as well. If, for example, I really need to look at an area with contrast, but someone absolutely cannot have contrast, then perhaps I could do an MRI with contrast. MRI contrast is different. It is a gadolinium contrast. It is not iodine-based and generally not as dangerous to the kidneys. And for an MRI of the brain, which is where we're usually using an MRI, you have to do it with and without contrast. A non-contrast MRI of the brain really isn't going to show anything small. So you want to do that with and without gadolinium, with and without contrast. How often do we do them? It depends on the circumstance, what we're looking for. At the beginning, when someone's diagnosed with ALK fusion-positive lung cancer, we're going to prescribe a TKI, alectinib, lorlatinib, several different drugs available to us now. And we have pretty high confidence these drugs are going to work. They almost always work, but almost always is sort of a key operative. And there can be some cases where we don't see those responses. Those are often cases of false positives, or maybe samples got mixed up, or maybe an IHC test was read incorrectly. So on the first scan, even though I'm very confident the drugs will work, I usually do that one a little bit sooner. These drugs work very quickly. And so if someone starts an ALK inhibitor, you're generally going to know pretty quickly if it's working. So I might do that first scan at 6 to 8 weeks just to sort of give myself some peace of mind that we're on the right track. This drug is working, especially if the cancer is in sort of a dangerous area, or an area where I really want to be sure I get a response, an area in the brain, a critical junction in the lung. I might do that first scan after about 6 to 8 weeks of therapy. After that, we do 3-month intervals, which is a made-up number. We've tried to do studies that vary the cadence of doing scans, but generally those are really difficult to do because people want to do them sooner, people want to do them later. Everyone has their own preferences. I think 3 months is my standard most cases, but what's setting the cadence of the scans? Well, generally we want to do a scan so that if this cancer were to start growing, if there was progression, I would want to see it on a scan before a patient had any symptoms, before a patient would notice it, before it would cause any problems. And so because of the general usual growth of an ALK-positive lung cancer, 3 months is usually enough time where if I do a scan at 3 months, if something's going to grow, I'm probably going to catch it before it causes major problems. It's not always the case. Sometimes these cancers grow quicker and unexpectedly. And so I leave that 3 months with an asterisk that we'll do our scan in 3 months. But if you notice something's wrong, if something doesn't feel quite right, we can do that sooner. And I do have some patients where there is a very high copay for scans, where we really have to balance the practical barriers to doing these scans. And Is 4 months just as reasonable? It is. 3 months is a pretty made up number. I don't know that there's much difference between 3 and 4. I think that doing a scan once a year probably isn't enough. I think doing a scan every week is too much. Where we draw those lines is a little blurry. We weigh the balance not just with cost and insurance, but also with the very real fact that there is some low dose radiation exposure with CAT scans as well. And so doing a CAT scan every day would be harmful, would be detrimental, would not recommend that. So always a balance. But the key here is we're doing a scan so that we can see if this cancer starts to be more active before it causes any problems, before anyone notices it. So roundabout way, Summer, to say I do about every 3 months.
We do have a first question from Randy. He has a brain MRI scans and he has to travel to a 3T scanner versus a 1.5T scanner.
Mhm.
I don't know if you have information on should he be doing that? Does it make a difference?
What is it? Should we
Scanner?
all?
Yeah, I mean, you really do want to have pretty state-of-the-art scans. It has to do with sensitivity and slice thickness as well.
Mhm.
You know, when we're doing trials, for example, we can't open, for example, the Nuvalent trial if you're doing if you have an old MRI or if you're doing 5 millimeter thickness scans, just because they're not going to be quite as accurate. And so does it matter? A little bit. I think it sort of depends on the unique circumstances here, but yeah, you really do want state of the art scans if you can get it. And if it's just a couple times a year, I do think it's worth making a way out if we can.
And I know the two trials that I've been in, you had to go to the same scanner, and you couldn't move to different hospitals for the scanner. So
Yeah,
I know a little bit about why.
there's a little wiggle room there. That ultimately comes down to contracting, and some sort of very boring, banal points about how trials are done. But when a sponsor opens up a study at a university, for example, they negotiate rates for these scans to be done. Because if we rely on insurance to cover a CT scan every 6 weeks, sometimes insurance will just say we're not going to pay for it. And then what does the trial do? Now the trial is kind of all messed up. And so the trial says, we will pay for the scans, but we want to negotiate these prices and make sure that we can afford to do this. We don't bankrupt the company for paying for everybody's scans every 3 weeks or every 6 weeks for a drug that hopefully works for many, many years. And so they negotiate these rates, but obviously those prices don't hold true elsewhere. And the sponsor can't pay for scans that are done outside the university. So that's usually why they recommend them there. I will say, Mark, just if it's just between you and me and no one else is listening, there's often a little wiggle room on those trials. And so if it's really impossible to do this if you're out of town, you say, I have to do this scan in Los Angeles, the sponsors will usually let you do it. That's just a little secret.
All right, thanks,
So
man.
good to know.
We have a lot of chat questions. So
I
I'm not
know, I
sure if
love
you
them,
heard a
but
couple
wait,
of
I
them.
want to stick with brain
Yeah.
for a second because
Sure.
this is a big one we see come up. And it's so great because our community flocks in with the answers, but let's hear you say, let's hear your response. So brain MRIs. So we talked about CTs, body CTs, maybe 3, and chest, abdominal standard, and then maybe bones you're monitoring. Well, bones, do you monitor that with a CT also if somebody had bone progression? How are you monitoring that? And is that every 3-ish?
Yeah, so bone's a little bit trickier. Imagine if you have a solid bone and there's an area of cancer right in the middle there. And if you snap your fingers, give an effective drug, that cancer melts away. And so now the cancer is completely gone, snap of a finger. There's sort of a hole there in the bone, and that's not good. And the body doesn't let that happen. And so what the body does is it sort of fills that up. It sort of heals that bone quickly, sometimes even faster if you're giving a drug like zoledronic acid or denosumab. And so you're going to heal that bone up. But now this healed bone is a little newer than that old bone that we've had our whole life. And so it's going to look a little different on that scan. You'll see the word sclerotic, which is sort of a thickened callus area, which is a little bit healed. But on a CT scan, it can be difficult to tell a difference between cancer that's growing or cancer that's responding to treatment. PET scan sometimes isn't too helpful either. Imagine if you had a small area of cancer that was undetectable on the CT initially, even on the PET, a very small area, cancer cells there, but not enough to register as an area of cancer. And then you give a very effective drug, and now the cancer goes away. And now the body gets to work at healing or repairing that bone. Well, that's also going to take up glucose. That's also going to be active. And so on the PET scan, it might look like the cancer in the bone is getting worse, when actually it's the opposite. It's responding to treatment. It may say there's a new area of cancer, but it might not actually have been new. It might have just been difficult to see at the beginning, and now I can only see it because the drug has worked there. And so bone can be very misleading. And when we're doing PET scans, one of the downsides with PET scans is, it can give information that can be a little confusing and maybe can point us in the wrong direction. And ultimately, if it only ends up generating anxiety, confusion, and other tests, there's a downside to doing PET scans too often. We have to do them under the right circumstances. When we're doing a clinical trial that's being sort of monitored by the FDA and we're reporting the official results, we have to have certain areas of the cancer that we're measuring so that at the end of the trial, we can say, this drug had a 75% chance of shrinking the cancer. We have to have certain target lesions that we identify that are easy to measure, that we can reliably measure. And bone is never allowed to be one of those lesions. Bone is not measurable. We can't use that as a target lesion because it is so unreliable, because it can look better when it's getting worse. It can look worse when it's getting better. And so bone is a little bit of a tricky one. Bone will show up on CT scan. If we see a new lytic lesion in the bone, that's generally signs of a cancer worsening or cancer being more active or poorly controlled. But when cancer is affecting the bone, when it responds, it will often look the same on the CT scans. So I forget the question, Summer. I'm sorry.
Would you monitor that? And then we'll hit brain and then some of those other questions, Mark. But so do you monitor the bones with an MRI then? Like if somebody has had treatment before, like how do you monitor that?
Yeah, so on the CT scan, if we're seeing sclerosis and not seeing new lesions on the CT, that's really satisfying as long as everything else is responding. I think if someone is having new symptoms at an area, then I'll look a little deeper in that area. And there are some among us who might do a PET scan, once a year or every other year.
Okay.
There's not really a firm consensus on how to use that. And again, we just don't want something to lead us astray. What I think would be a real tragedy is if a drug was working really well. If I had a patient where this was a drug that was going to work for the next 10 years, and then I got a PET scan that maybe sent me in the wrong direction and I changed therapy too soon. I sort of deprived someone of a drug that was going to work for a long time and put us sort of in a sticky situation. I think that could be detrimental. So we have to be careful with some of these tests that are difficult to interpret. But bone is a real challenging one. We're still looking for new markers, new tests to measure bone. There are a couple interesting assays, interesting tests in development, but bone's always been a challenging one for us.
And so
You
then,
prescribe,
sorry, with that, and I was just gonna, so that would be monitored or be able to be picked up in quarterly scans. You would be able to see from a CT if there was a hip metastasis.
So if there's a new area of bone spread, then yes, that should show up on a CT.
And then would you also just do symptomatic, like because you only are doing regular CTs on the chest and the abdomen and pelvis. So
so if someone had symptoms, direct me somewhere else. Absolutely.
Okay. And do you feel like, is there a more common area of bone progression, someone asked?
I think spine is a very common one, spine and hip, but they're just because they're sort of larger bones that we see. People ask, can this affect a foot bone? I would say there's no reason it can't. It's not something that I've seen. It's not usually part of our regular monitoring, but if someone is having symptoms, then certainly I would direct some imaging towards that.
Question about the bones. Would you prescribe a bone strengthening medication?
It's a good question. So right now we have 2 drugs that we frequently use for cancer that's affecting the bones, cross lung cancer, and that's zoledronic acid, which is a bisphosphonate given intravenously every 3 to 4 weeks, or denosumab, which is a rank ligand agonist, and that's given subcutaneously every 4 to 6 weeks.
Zometa?
Zometa is zoledronic acid. Yeah, the first one. Zoledronic acid can affect the kidneys. And so if the kidneys are struggling or damaged in some ways, then Xgeva or denosumab is a safer drug to give, but it is more expensive. So insurance can fight that sometimes. When we give those drugs, it's important that we're giving calcium and vitamin D with them because they can lower our calcium. And what those medicines are doing, they're not fighting the cancer. They are not cancer treatments. They don't make it less likely for cancer to spread to the bone. They don't help get a response of cancer in the bone. What those drugs do is they reduce the risk of skeletal related events, which is sort of a term we use, not consistently actually through different trials, but things like fracture, pain, spinal cord compression, hypercalcemia, cancer-related complications of bone. And the studies weren't done specifically in lung cancer. They were just on cancer in general. What they showed is giving those medicines reduce the risk of fracture, pain, things of that nature. I think they can be helpful. I don't know that they're essential, and it's generally not something I start immediately. I don't think there's anything wrong with starting them immediately, but at the beginning, when we're starting a drug like a TKI, I'm watching to make sure it's working, but I'm also watching for side effects. And I really don't want anything else to complicate the picture. And so if someone has, for example, a rise in creatinine or some kidney issue, if there's some doubt in my head, is this from the Zometa or is this from the TKI? And it leaves me questioning things. I like to keep it clean up front. And the benefit from drugs like Zometa and Xgeva is really long term, not sort of in the short term. So once I'm sure the drug is working, people are feeling well, that's usually when I'll introduce them. And I do think there's some value in them, but there's some risk as well. And the risk is with something called osteonecrosis of the jaw. When we think of accelerated bone healing or growth, that's generally a good thing. We want those bones stronger quickly. But if, for example, we have a root canal or someone extracts a tooth, we don't want that to heal in a haphazard way because the jaw is very sensitive, very specific, and bone needs to heal in just the right way. So if we have sort of uncontrolled growth in that area, it can really affect eating, chewing, talking, movement of the jaw, which can have a really powerful, profound effect on the quality of life. That is a rare complication. It's more common if you have a big dental procedure while taking those medicines. So dental procedures are something you should do beforehand and not while you're getting these medicines. It's rare, but the problem, Mark, is that when it happens, we don't have good treatment for it, and it can be absolutely devastating. So my own practice, there's not a lot of data behind this, but I know some of my colleagues have a similar practice, is I will use those medicines, after we establish safety and efficacy of the cancer treating drug. I'll add those medicines for support about once a month, a lot of flexibility, but about once a month for about 6 months. And then after that, I'll probably just go to once a year. Again, not a lot of strong data to support that regimen. The studies used them for 6 months and then left it to the investigators to how long to give them. But I do think there is a cumulative risk in terms of osteonecrosis, and I don't know that you're getting the same return after the first 6 months. So after about 6 months of treatment, I usually taper that to once or twice a year, depending on the burden of disease. And if someone were to omit that and not give that, I don't think that's malpractice. I don't think that's absolutely necessary. In fact, some wonder if we should be using it at the beginning when a drug like alectinib or lorlatinib works so well, and should we be saving it for 10 years later when those drugs start to falter? And that's probably reasonable as well. So not strong studies done in that area because those drugs are coming off patent, and that would be a very difficult study to do. But generally, I'll do it about about every month for about 6 months, and then maybe once a year.
We do have a question about ground glass. Is that considered to be progression?
Wait, could we just wait 1 second for that? I want to come to that too, but I just want to keep us on track a little bit. So hold with the ground glass for 1 second. I do want to ask about that, but sticking with the bones. Okay, I'm not going to say this right, but densomab, using that after you see the bone sclerosis, or can you tell us?
Yeah, you can. So denosumab is Xgeva. That's a subcutaneous bone strengthening drug. And so the same things would apply there. And so the timing of it's not so critical. That's not an emergency. The important thing is to really start the ALK TKI to make sure it's safe, to make sure it's working. And then the bone strengthening drugs, I think, can be helpful, but they're not the priority.
Gotcha. Perfect. Thank you. Sorry. And then also, just again, so we all are comfortable with this as we talk about bone progression, the CT also picks up your ribs or your spine. Like, yes, they all, our oncologists zoom in and show us our lungs and look, this is where it was before and now it's shrunk, or, maybe something popped up, but also you are seeing the bones in there as well.
You do, but if there's small growth in the bones, sometimes a patient can feel it before we see it on the CT, and that's why it's important that we listen to patients. The patients tell us, "Scans look good. That's great. I'm glad for that. I feel that something's not right over here," and so then we might do an MRI or a PET scan or something to look a little more closely at that area.
Perfect. Thanks. Okay, Mark, go ahead.
Sorry, I didn't get my cue. Ground glass, I know it shows up in a lot of our scans results. what do you think about that? We just call that progression?
Well, it depends. And so ground glass is a term we would use to describe what something looks like on a CT scan. And it's sort of a hazy, non-solid spot. That's what we would call a ground glass nodule. And ground glass can be related to cancer, yes, but it can also be related to infection. It can be related to inflammation or focal pneumonitis. It can be related to someone getting a cold or COVID or pneumonia. It can be related to the medicines. Drug like alectinib or lorlatinib can sometimes cause some small ground glass changes that might disappear over time. So it really depends on the nature of an individual person's cancer. And this is why it's really important, I think, to have a strong relationship with the oncologist. That, I know of some patients that I've been treating for 7 or 8 years. And at the beginning, their cancer was largely ground glass. And so if I saw new ground glass opacity in the lung, I might pay a little more attention to that than someone who's always had very solid tumor nodules and had waxing and waning or ground glass nodules that come and go, maybe related to the type of work they're doing, or maybe they've got young children at home where they run a daycare and they're getting colds, different colds every day of the week. And so that might be what I'm seeing. So it really is pretty individual. Ground glass describes what they look like. It can be related to progression, but ground glass is often very vague and nonspecific.
So what would you do with that patient? Would you just monitor that patient for another scan or what?
It depends. Someone who is symptomatic with a lot of ground glass changes. Well, now that sounds a little bit like pneumonitis, for example. I might need to give steroids for something like that. I might, if someone had fevers with a lot of ground glass changes, I'd say, well, it sounds like maybe you're developing a pneumonia that might not be related to these treatments, but might need its own therapy. Whereas if I saw the ground glass changes that really mimicked the person's cancers that were growing, it depends on the extent. It depends on how many and how large. But I might, for example, do a biopsy of that area to be certain, and it might warrant changing treatment.
And why would certain clinical trials not allow you in if you have pneumonitis?
Generally, when we're running a clinical trial, if I enroll somebody on a clinical trial, the parties that are involved, myself and the cancer center, the patient and their family, and the sponsor, the drug company or the NCI, whoever's supplying the drug, we all want the same thing. We all want the drug to work. We want the drug to work immediately with no side effects forever. That's what everybody wants. But to be very transparent, we want it for different reasons. Now, the patient and I would want it to help this patient, to make them feel better, to make them live better, and to live longer. That's why we want it to work. The company, while I'm sure they want the best for everybody, they want it to work so their drug can be approved by the FDA so they can sell their drug to the world. They are a company, they're a business. And so that is their motivation. Same goal, but different reasons for that goal, to be very clear. It's not a charity. These companies are doing it to get the drug out there. And while they want to help people, they need to earn a profit for their shareholders. That's sort of what they do. And I think it's best to just go in with our eyes wide open. And so as a result, they want to make sure that the world knows how good their drug is. And if someone is having a lot of side effects from chemotherapy and they've got a lot of kidney damage, well, now this company says, well, if we give this new drug, if we give our drug to this patient and his kidneys aren't working too well, maybe he gets sick from the treatment. It's not really from our drug. It's from that chemotherapy he got last month, but they're going to say it's from our drug and it's going to make our drug look more dangerous than it is. And so they really write down a list of inclusion and exclusion criteria, a list of sort of different characteristics where the patient needs to qualify for that study. And what they're doing is they're really saying people that are too sick or people that might have what look like side effects to our drug, but are not side effects to our drug. We need to keep those people off of our trial. And once the drug is approved, a doctor can give it to whoever he wants. But it might cloud the results of the study. And, as it may seem in some cases sort of heartless to exclude those patients, but again, we don't want to kill the drug. If the company allowed everybody on that, and then they say, well, you know what, everyone got pneumonitis from this. It's like, well, these were all people that had pneumonitis going into the study. We don't think the drug caused pneumonitis. The FDA says, look, everyone who got the drug got pneumonitis. This drug causes pneumonitis. We can't approve this drug. Now this drug is available to no one. So it's a balance of things. And I think that we've had meaningful discussions with companies to remove some exclusion criteria that we don't think should be exclusion. For example, HIV. I think in 20 years ago, where we weren't quite as comfortable with HIV, people said, well, people with HIV might get really sick from our medicine, and so we don't want to include anyone with HIV. Whereas today, we'd say, well, that's not really fair to someone who has HIV, and there's no data to suggest that they would be at a greater risk for side effects from this targeted drug, and it should work just as well. And so many studies do not exclude someone with HIV. And so I think we've made some progress there, aligning those goals. But if someone had a history of pneumonitis, then they're a little more likely to get recurrence of that pneumonitis. And pneumonitis is a tricky one, right? If someone has pneumonitis from immunotherapy and they're treated with steroids and it gets better, a month later, out of nowhere, might just come back. We don't fully understand the immune system and how it triggers attacking the lungs and causing those pneumonitis results. So many studies will exclude any history of pneumonitis just because they might suddenly get pneumonitis that's not related to this trial medicine, but would look like it's related and would make the drug seem more toxic than it is, and might prevent that drug from being approved and available to everybody else.
Makes sense. Summer?
That was such a great question, Mark, and great answer, Dr. Liu, because that is something that's always so frustrating for us as patients, right? Because we're like, this is our chance and we need, this is what I need to stay in the game. And maybe we don't qualify, but it is such a good point that the goal is to get that drug to market and show safety and efficacy. So thank you for that. Okay, how about circling back? Because if we were having a real life conversation, that's how my conversations go, like this, and then I need to bring it back. Okay, to the brain. This is what I was going to say, is that becomes a hot topic in our support groups. We know like people that have had brain metastasis, maybe initially or later on, that they're monitored more closely with brain MRIs. And then if not, if you have not had metastasis, typically we see that it's 6 months. Sometimes people go a year. And then there are some people that say, I had one when I was diagnosed and now it's 3 years later. And my oncologist, like, should I ask for one? And that person, I'm so glad that they voice that, because they are quickly jumped on by our whole community. But it's such an important point and question. So can you lay out the timeline kind of for the brain, please?
Yeah, so I think the key with monitoring the brain is we really want to know if cancer spread to the brain before it causes any symptoms, before it causes any problems. It's such a critical area to maintain disease control. And we know certain types of cancers are just more likely to spread to the brain. It's just in their programming. And ALK is one of the highest in terms of likelihood to spread to the brain. And so an MRI of the brain with and without gadolinium contrast is an essential part of staging, needs to be done at diagnosis. And I would say at a minimum, needs to be done once a year. And in my own practice, that would be regardless of stage. And so even someone had a stage 2 lung cancer cured with surgery, I would recommend that patient get an MRI every year, probably forever. And so I think MRI is critical. Now, if someone has cancer affecting the brain, we're going to watch that area more closely, because if someone has a cancer in the lung that's spread to the brain and we give a TKI and I do a scan, a CT and an MRI, and I show it's working, I need to continue to do scans to make sure it is continuing to work, because I know that for most people, the cancer will eventually develop resistance. And again, purpose of the scan is to pick that up before it causes any problems or symptoms. And so that means doing both the CT and the MRI. And so when we talk about 3 or 4 month intervals, that would be for both. Now, if someone has never had spread of cancer to the brain, I might not need to follow it as closely. I would do it at a minimum of once a year. But in a stage 4 setting, a cancer that's already acquired the ability to spread, I think the risk is a bit higher. And so I'm more likely to go twice a year there.
Oh, great. Thank you so much.
Can you
Okay.
expand the brain though?
Say that again?
So as we're talking brain, I have a couple questions for you.
Sure.
That is, I'm gonna give you a scenario. Electing a patient comes and has one spot on the brain, and you can't get any result from the blood biopsy of why they're progressing in the brain. Would you just zap that, or how many spots or size of the metastasis would you consider to flip to a different TKI?
Yeah, so I think it's easy to think at the extremes, and so one small spot, yeah, I would probably radiate that with stereotactic radiation. If it's less than a centimeter, it might just be one treatment, and if it were 100 different spots or many spots, then I think that that radiation might be a little challenging. It might be beyond the capabilities of stereotactic radiation and more amenable to something like whole brain radiation, which carries a lot more risk in terms of neurocognitive effect afterwards. And so in that setting, I would switch to probably a different, more brain penetrant TKI if one were available. But the reality, Mark, is most people are somewhere in between. And so two spots, I probably treat. 10, I think it depends. And, not all brain spots are equal. If something is in the frontal lobe, that is something that's very easy to treat. If something is in the optic chiasm or the cerebellum, it's a little trickier. And so I think it depends on the size, location. Ideally, we pick things up when they're very small. They're much easier to treat. This is the reason why it's good to do MRIs on a somewhat regular basis, so that if they do happen, we can make those changes. When we see growth of a brain lesion, or we see a new spot in the brain, I think the timing is also important. And so if someone's been on alectinib for 4 months, and now I suddenly see a new spot in the brain, does that mean the alectinib had stopped working and then a new spot of cancer spread to the brain? Or is that a spot that was there from the beginning and alectinib has shut everything down, but that one spot in the brain was just a little too small to see back then, and it's just been growing very slowly? And then maybe if I were to radiate that, alectinib might still be the answer for the next 10 years with a very high quality of life. And so I think a little bit of it depends on the timing. Is this an early event or is this a later event? And there's a little bit of an art to it. When we see changes on the scans, whatever the scans are, the real qualitative question is this a sign that this drug is no longer the best treatment? Because thinking, is the drug working or not? I think it's a little bit too black and white. And I think there's a lot of gray there, because when these cancers spread, they do not evolve together. So if we have, a cancer that's spread to 4 different places, now those cancers might evolve or mutate or change in completely different ways. They're not synced up. So we might see resistance at one, but it might be a totally different mechanism of resistance from a different spot. And so I think qualitatively we ask, is this drug still the right medicine? Is it still helping this patient? And you have to think of, where was the cancer when we started and where is it now? And, areas of progression, what are our different options? And changing treatment wholesale is, often an option, but it's not necessarily the best option. And, sometimes we can still get a lot of benefit from that drug if we just sort of take a few bad players off the books. And so that's where we use things like ablation or radiation or cryotherapy or surgery even, to say, well, this cluster of cancer cells, whether it's in the brain or the lung or the liver, this cluster's figured out alectinib. This cluster's figured out lorlatinib. And so now we need to switch everything, or can we just get rid of those ones? And, is lorlatinib or alectinib destined to keep working on everything else for the next decade? Because if it's the latter, well, I'd hate to prematurely throw away a drug that still has a lot of good use to it, right?
Somebody see anything?
Yes, I was going to ask about leptomeningeal disease, please. We did have a question about that, but if you could explain what that is and can that be picked up on your standard brain MRI?
Yeah, it can. But again, this is so there's a lot of nuance to it. And sometimes those things can be missed. And that's why I do think there's value in going to, when we think about doing MRIs, and this applies, I think, to the question earlier about the model and the type of scanner, it's not just the test itself. It's the, how frequently you're doing the MRI, we're doing it with contrast, how, thin are the slices, but how modern is the machine? How clear are the images? And really, how experienced are the technicians doing the test and the radiologist reading it? And so I do think that it kind of matters where the scans are done. And, if you're getting an MRI at the mall in the drive-through, it's probably not going to be as good as a university MRI. And I completely appreciate that sometimes it takes longer to schedule the MRIs university, and longer to get a report sometimes even, and it seems more convenient to go down the road to a strip mall. But if you do get MRI somewhere else and you're showing the images to your oncologist, just ask him, hey, is this a good MRI? He says, well, actually, it's pretty bad, and maybe he's afraid to say that because, and you say, well, I can come here. It's, and so don't be afraid to ask. Also, just while it's there, you really do want your oncologist to look at the pictures. The report, the words, those are, they don't carry as much meaning. When you've been doing this a while, you can see how unreliable some of these measurements are. And even though they might report things to the millimeter, generally, if someone's measuring something 10 times in a row, you're going to get 10 different measurements. So if things are changing by a millimeter or two, usually it's not a significant change, but sometimes it could be. And it's not just the size, it's also the quality and the nature of what it looks like. So, you really want an oncologist that's looking at those pictures and should be able to look at them with you. And if, you're getting treated at University of Arkansas, but you're getting your scan done at a community site in Arkansas, you need to bring that CD with them, and they should be able to look at it with you. And so don't be afraid to ask about that, because I do think there's a lot of value in that. But back to the original question, which I do forget.
Leptomeningeal. How does it show up?
So it should be picked up on CT scans. What is leptomeningeal disease? So when we think of cancer affecting the lung, often it'll be a nodule, a mass, a tumor in the lung that I can see that looks different from the surrounding area. It's a solid mass. And so if we did surgery, we would see a cluster of cancer cells that is different than the surrounding lung. But sometimes cancer can affect areas that aren't a solid, for example, a pleural effusion. Around our lungs, we have a small amount of fluid to lubricate the lungs. That's normal. Well, sometimes cancer can get into that space, and we can see cancer cells in that fluid, and it causes a lot of problems. It causes sort of an overproduction of that fluid, and it prevents the normal drainage of that fluid. And so the fluid accumulates and causes shortness of breath, and causes pain, and cause the buildup of pressure and a lot of problems. And so when cancer affects the fluid, that can be a real challenge. Well, the other area where we have fluid always in the body is around the brain. And while we have cancer that can affect the brain, that we can see a solid nodule or tumor within the brain, sometimes that cancer can affect the fluid that coats the brain and the spinal cord. And that it would be something we term the cerebrospinal fluid, or CSF. And when cancer affects that space, it's a real problem, because there it's not cancer in one specific area that we can radiate or that we can remove with surgery, but it really is in the entire fluid that's covering the surface of the entire brain and spinal cord. And it can really affect any neurologic function, because it's almost like sprinkling sand over a set of gears, that it's really going to get everywhere and move everywhere. And those symptoms might be inconsistent. They might be transient. They might be migratory. Someone might have neurologic symptoms related to an eye twitching, and then that goes away. And like, oh, I guess that was nothing. And then the tongue doesn't move properly, and then that goes away. And now the arm doesn't work properly. Say, wow, it must be something, a transient, maybe infectious, but that's how leptomeningeal cancer can affect us. It can affect any part of the brain at any time, completely unpredictable, and it really can be devastating. Treatment for leptomeningeal are limited, and it really depends on sort of where we are in the treatment course, and whether it happened at the beginning or whether it happens after prior therapy. If we see leptomeningeal disease from the start, well, fortunately, the drugs we have, the ALK inhibitors that we use today, are very good at penetrating through the blood-brain barrier. It can be very effective in the brain and for leptomeningeal disease. And while it is the sign of a cancer that's serious, a cancer that might be more challenging to treat, a drug like lorlatinib, for example, or NVL-655 would be very effective in the setting of leptomeningeal carcinomatosis, leptomeningeal disease. And so if it's present at diagnosis, I would expect the drugs we use today to be effective there. If it occurs later in treatment, if someone, for example, was taking Xalkori or crizotinib, and I know that no one here is, but if someone were taking crizotinib and then developed leptomeningeal disease, well, then changing to a treatment like lorlatinib would, again, be expected to be very effective. But if leptomeningeal disease occurs while taking lorlatinib, that's real challenging. And unfortunately, that can occur. And, what can we do there? Can a drug like NVL-655 be effective there? We don't know the answer to that. And so We have different treatments, but to be honest, Summer, none of them are great. We work closely with our neurologists and our neurosurgeons. We might use chemotherapy, carboplatin, pemetrexed, and sometimes bevacizumab or Avastin. Those are drugs that can penetrate through the brain and they can be effective. But it's widely variable as to whether they'll work or how long they'll work for. In the past, we would give chemotherapy right into that space, either introduced through a lumbar puncture or through a port in the head, in the skull. That's called an Ommaya reservoir, and that's a way to deliver medicines into that space. I'll tell you, Summer, that it's fallen out of favor because it is a toxic treatment. There are a lot of side effects with that treatment. And when that treatment is given, unfortunately, it doesn't work for all that long. Now, there are some extenuating circumstances, there are exceptions, and certainly I've had in my own practice cases where that has been effective for a long period of time. But it is really challenging, and sometimes it's a cancer that doesn't respond to that treatment. We can offer radiation, but it's not stereotactic radiation like CyberKnife or Gamma Knife, because you're radiating all of the fluid, not just one spot. And so that really means you're radiating the whole brain and the spine. And so that's something we call craniospinal radiation. And it is something that we've done. And at Georgetown, we try to do that with proton beam therapy, which is a little bit less toxic. I know that's the practice at Memorial Sloan Kettering as well. But again, a mixed response in terms of results and how effective it is. So when we look at new drugs like NVL-655, we look at new agents, we're looking at all the details and how well they work. We certainly want to report what is the response rate. How likely is it to work? How long will it work for? What are the side effects? How long until we see progression? But we also want to capture what are the details of progression. Because if we look at progression-free survival, how long the drug works until we see the first signs of cancer growing, it's a number. But behind that number, because you mentioned earlier, it's not a matter of if, it's a matter of when. But I actually think all the other details are just as important. It's not just when, it's how, it's where. And so if a new drug comes along and has the exact same progression-free survival as lorlatinib, but we see 0 cases of leptomeningeal disease, well, then I think there's value in that. And so I think those are the kinds of details that we really want to pay attention to.
Great information for all of us. Thank you so much. Mark, anything? There's so many great questions in the chat. We could keep you here all night. Some of these we'll have to bring to Summit with us, and some we covered a little bit in the green room before that then I can share with others in our group. Mark, anything jumping?
Yeah, please walk us through. You have a patient comes in and he's progressing or she's progressing. What steps do you take, and what happens if those blood biopsies or even a tissue biopsy comes in and you don't get a red flag of what's going on?
Yeah, which happens a lot. And so we think of progression, there's different terms of it. And if you're reading trial results, progression is actually a defined term, and it means a growth in the estimated volume of cancer by 20%. And so a 20% growth in volume, an estimated volume, is our definition of progression or a new lesion. But I think that colloquially or clinically, when we use the term progression, I think what we're trying to say is a cancer that's no longer adequately controlled with the drug we're giving, where this drug is no longer the best possible treatment out there. So what do we do in that setting? And first, if we see growth of a few millimeters, understand that it might be inaccurate, that sometimes these cancers can wax and wane, they can grow and shrink. And so if someone has no symptoms, we might sort of leave that alone. It's not unusual to then see that regress a little bit and to see the drug continue to provide good control of the cancer for years after that. But if it's become clear that this drug is no longer the best option, what do we need to give? And, we want to try to find out what's changed. If a drug was working and it stopped working, well, then that suggests the cancer's changed in some way if we're still taking the medicine. And we want to find out how that works. And so we'd like to do a biopsy. And ideally, you do a biopsy of the area that's growing. So if we see a new spot in the liver or something growing in the lung, we want to biopsy where we're seeing growth. And the biopsy can then be compared to the original tumor and say, what's changed? Something's changed. And if we can just figure out what's changed, we can adapt therapy. So if we see a new spot, we biopsy it. Maybe now it's a small cell lung cancer. Well, that responds to a different type of treatment. Maybe we see that original ALK fusion, but now we see a new MET amplification that wasn't there before. Well, if the cancer is now using MET as a backdoor, it's using MET to survive, can we give a drug that blocks MET and then maybe combine the ALK inhibitor plus a MET inhibitor, and that's been effective. That might happen about 15% of the time. But Mark, to your point, we generally don't find anything. And really it is the question of, do we find something where, we clearly have a right answer, like a MET amplification, we give a MET inhibitor, a specific ALK resistance mutation where we might give a newer ALK drug. If we see something that points us in a clear direction, that's easy. If we don't see that, do we see something that points us away from it? For example, if I see a KRAS G12D mutation, or if I see, KRAS amplification, well, we don't have a drug for that right now, but it tells me that giving a better ALK inhibitor probably is not going to help, that the cancer is not really relying on ALK to signal. And so it might point us towards a treatment, but it might point us away from a treatment. So if I say, well, we're on alectinib and, I've got lorlatinib here, I'm going to do a biopsy. It's like, ooh, I see a new KRAS mutation and it's clear that this is driving resistance. Well, I don't know that lorlatinib is really the best treatment here. And maybe this is a case where chemotherapy is a more effective therapy. So it might point us towards something, it might point us away from something. And if we don't see anything, well, I think we play the odds, unfortunately. And not seeing anything doesn't mean the cancer hasn't changed. It just means that we're not capturing it due to the limitations of our test. You mentioned liquid biopsy, and we do that all the time because it's very easy to do, but it's not as sensitive as a tissue biopsy. The reality is oftentimes a tissue biopsy is just not possible. It's not feasible based on where that cancer is. It's not safe, or it's just impractical. And liquid biopsies are very easy, and sometimes they give us a clear direction. But if we don't see anything, it doesn't mean the cancer's changed. It just means we don't know how it's changed. And so unfortunately, it's a little bit of guesswork. And so should we use a different ALK drug like lorlatinib or like NVL-655? And I think it is reasonable to do. But again, a lot of it depends on the specific circumstance. And if someone has asymptomatic growth where there are no symptoms or something dangerous, absolutely, let's try an oral drug with fewer side effects. And if it doesn't work, we'll then switch to something else. But if someone's really symptomatic, and I'm really worried about resistance here, I might go with chemotherapy, knowing that this will cover things, whether it's ALK or something outside of ALK, and maybe we can revisit an ALK drug later. So again, I think it's very individual and something the patient needs to discuss with their doctor. But biopsies are I think necessary when possible, and they can really give us a lot of valuable information.
So the last few years, we've used combination chemo and TKIs.
Yeah.
So if you have an alectinib patient who's progressing, would you just add chemo to that, or will you always switch to lorlatinib plus chemo?
It's a good question. We don't know the answer necessarily. If we look at the early EGFR studies, we base a lot of what we know about targeted drugs on EGFR because it came first. When people were taking the older drug called gefitinib, when that stopped working, they randomized people to get chemo alone or chemo with gefitinib. And they said, does it matter if we continue the drug? Is it doing anything, or is it just an expensive drug and it's just adding cost? What was interesting is continuing the EGFR inhibitor in that study, not only did it not improve outcomes and rise up the cost and toxicity, actually numerically, people not getting the drug lived better. They lived longer. The survival was better in people that stopped the drug. Now, I don't know that that's true with osimertinib, and I suspect that it's not. And again, I think the value of continuing the newer drugs is that it maintains control within the brain, something that chemotherapy often falls short in. So I think there is value in continuing alectinib and lorlatinib when we can. But I acknowledge that can increase the side effects of chemotherapy, can lower the blood counts a lot more. And unfortunately, insurance sometimes doesn't cover the cost of that. So how do we change that? We need to study it more. And there really aren't studies there. If we had a study that said, it is better to continue lorlatinib or alectinib, then insurance companies would do it. And then we would have more knowledge about the safety and can we do it for everyone? Do we need to adjust the dose? But we need to do those types of studies. And those are big studies. And unfortunately, there's just not a lot of funding to do those types of studies.
Yeah, we're at 8:02 now, and I just wondered before summer starts, give us a little preview of our summit. Is there any closing statement you want to make before we see you in 2 weeks?
Well, just an apology. I tend to be a little long-winded, and I know that sort of cut our time. That's why my clinic is always running a little bit behind because I go into some tangents here, and I'm sorry I wasn't able to respond.
No, this
also,
was
yeah, I wasn't able to respond to questions in the chat because I'm really bad at multitasking too, and I can't listen and type at the same time. I can't talk and drive time, so I apologize for that. But I think that it's a valuable community here. These are all the right questions, but if other questions come up, you got to make sure you talk with your oncologist too. And it's really important that you have a strong relationship. That you have an oncologist you can really talk to and ask these questions about. These are all wonderful, appropriate questions. And, we use a lot of terms and we make a lot of assumptions here. And if something doesn't make sense, do not be afraid to ask. Everyone's happy to explain it. I think that oncologists love talking about oncology. Everyone loves talking about what they do.
Great.
This has
Summer?
been fabulous. Please, no apologies at all. We love the tangents. We're all here soaking it all in. You did such a great job in making it so relatable to all of us. So this has been great. Thank you. And thank you so much, everybody, too, for your participation and for all of your questions to help make this so meaningful and to dive deeper. And I've kept a list to see ways that we can incorporate your questions into our summit. Into some of the case studies or into our Ask the Expert breakouts. Dr. Flores on Sunday is doing an Ask the Expert side effects and self-care. So a lot of these can filter into that. Also, there were some questions about alternative therapies. We had a great talk a few months ago with two oncology pharmacists from UPenn. So you can check out what they had to say also. So really, everybody, thank you so much for participating. But hold on, Mark told you that we were taking a little hiatus until September, but we still need your help. You have some homework to do to make the summit better than ever, whether you're in person or virtual. We need to see your smiling faces on screen. Katie Delaney right now is going to post our little call to action. Get on it, everybody. 3 things that we need. You have a choice of 2 videos. One, you could do a video recording of yourself, brief favorite words of wisdom or advice. You could give life advice, or it could be living with cancer. Something you might tell somebody newly diagnosed. Again, how do we all get out of bed every day? It's because of this community. It's because of our amazing oncologists, and it's because of each of you. You are not alone in this, so lean in and make a video. Your second video we need to see is how you're living your best life. That can be anything. It could be, oh my gosh, I can go to the grocery store with my baby. It can be yourself on Bahama vacation. It can be riding your bicycle. It can be, I can walk up the stairs today. Whatever it is, add that flair of humor. We love it. And then third, wait, I forget what third is, a picture. Okay, send us a photo of you and your pet. No pet, no problem. Whatever. It can be a stuffed animal. It could be your goofy sidekick, whoever. Any photo will do, but please also send us that way. So check out the chat. Yeah, and I
Plus, we
can't.
need your blood.
Yeah, and thanks, Mark. We need your blood. University of Michigan needs your blood. And also did they open it up to care partners living in the same home this year too, which is huge. So also, if you're going to be at Summit, you can sign them up. And I believe they will even do virtual participants at this point, just in the US due to cost effectiveness. But you can also participate virtually as well. I believe they send you a kit once the summit has closed. So please, please, please register. We're at 88, I think, and Kirk Smith is putting out a challenge to the community. Like, we got to get that way up there and get our numbers up. As I say that, Mark and I still have not registered. So don't do as I do, do as I say. And get yourself registered for the Michigan Blood Draw. Thank you all so much for being here tonight. And if you would like to unmute, please, and say thank you to Dr. Lou, who took time away from a Sunday evening to join us for our little summer bonfire. Dr. Lou, thank you so much.
Thanks, Sarah.
Thank you.
Thank
you.
you.
Thank you.
Dr. Lou.
Thank you.
Thanks, Doc.
Thank you. Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank
you.
Thank you.
I'll
Thank
see you.
you.
We'll see you at
Have a
Summit.
great night, everybody.
Take care.
Thank you.
Thanks.